یارا کتو اسم من آرزو ملیحیه. من از ایران اومدم و تهران متولد شدم و یه 8 سالی که در نیوزیلندم. خیلی خوشحالم که الان پیش شما. So I was saying, my name is Arezoo Malihi. I'm a research fellow at University of Auckland. I came originally from Iran. I was born in Tehran and came to New Zealand about 9 years ago. So I'm very happy to be here with you today to present some of the work that I've been doing on refugee studies for the past 3 years. I mean, this work is funded by Auckland Medical Research Foundation. Funded last year, but there are a lot of collaborators over the years that helped me, and a lot of researchers helped me to do this research. So thanks so much for the opportunity. And here is about mental health of refugees, and this is the disclaimer. So the results are not official stats; they have been created for research purposes, and so the results of the presentation is all my work. So to identify refugees, I used IDI, Integrated Data Infrastructure. I found refugees through Immigration New Zealand. And Annie, who's sitting here 3 years ago, helped me with setting up the cohort initially. So that wasn't an easy task, but we managed to find them. So whoever who came to New Zealand since, and the data was available from 1997 through to we did like our cohort through 2020. So whoever who received a decision as a refugee or asylum seeker or as a family support category, who's the person who was supported through a former refugees here to come here, are included in my data. Then I used other databases, mental health databases, to find any infraction related to mental health service utilization. And I used the social well-being agency a method to identify mental health conditions of refugees, which I'll get to that later. So why researching refugee mental health is important? I think it's very important because over time we are having over 100 million forcibly displaced people by the end of 2022, and that problem is everybody's problem, I think, around the world. And like New Zealand has increased its quota, doubled its quota actually. In 2020, which means that like 1,500 people annually are coming to New Zealand as quota refugees. These people are identified by UNHCR, and they are coming as residents. Then we also have family members. We doubled the number of people who will come on their refugee family support screen. So these people are like 600 people annually are coming, in addition to asylum seekers who are applying for asylum from within the country because of the changed situation, their situation in their own home country. So all of this means that we need to be prepared for a number of people who are coming to New Zealand, and like potentially they might have been traumatized, going through conflicts, wars, and so we need to know what are their needs and whether we are providing enough for them. So the main aim was to understand the purpose. So we can't understand how many people needed help. We just can see how many people utilize services within IDI. And that hopefully in the future we can do some surveys to understand the mental health needs of refugees. But what I did was I looked into initially the PRIMED, which is mental health service utilization database, specifically within Ministry of Health. I looked at different refugee subgroups because refugees who are coming as quota, they receive settlements, like 2 years of settlement programs for them. And then they're coming in the first 6 weeks, which is now 5 weeks. They go in the Mangere, and in the Mangere they receive some screening, health screening, including mental health screening. And like Refugees and Survivors New Zealand, RAS New Zealand is there to provide them with mental health support if they are identified as needing so. but other refugee subgroups are not going through orientation programs. And so there are different services available to different refugee subgroups. So first of all, I wanted to identify whether there's differences between refugee subgroups, and then how refugees were differently utilizing services compared with the New Zealand population. And then secondly, I wanted to identify from adding our other databases data, from hospitalization data, the disability support service data, laboratory data, and Ministry of Social Development incapacity events data to identify mental health conditions of refugees over time. So this is a flowchart of how I identified adult refugees. So this cohort doesn't include children, those who are aged 16 and above. And together, about 25,000 people who arrived in the country from 1997 to 2020 are included in this analysis. So the first one is the prime. So how many people utilize specialist mental health services? So this table, I'll follow up in the next figure, that will be easier to read. But this table shows that asylum residents, which are those asylums who stayed in the country but they didn't become conventional refugees or weren't identified as refugees, but became residents through other pathways. And conventional refugees who applied from within the country and received their refugee status later, and family groups. These groups have utilized services much very less likely to utilize services than the cultural refugees. So perhaps this one shows it better. The pointer here. So this is odds ratios. This is results of adjusted odds ratios, which shows other refugee subgroups compared to quota have been utilizing services much lower. And then women were more likely to utilize services than men. And there were some differences between age groups, but the main ones that are these three these two, 25 to 44 years old, were more likely to utilize services than the older adults. So this is time to the first event analysis or hazard ratio analysis. As you can see, cultural refugees they start with an increased utilization rate, and I suspect this one would be an impact of NGOs or RAS New Zealand in the first 5 weeks of orientation program, because this is time from arrival and months to the first service utilization. As you can see, cultural refugees were more likely to utilize services than the other subgroups, followed by the convention, asylums, and then lastly, and the family drops here. So family group started from 2003, which means that they were, the time in the study was lower than other subgroups. Mm-hmm. Then the next question for me was, okay, so if there are a higher proportion of quota refugees utilizing services at all, the first service utilization, so how is that do they also receive several contacts? Were they followed up, had several meetings or face-to-face contacts or not? All of these are based on face-to-face contacts. So if it was just a telephone conversation, it wouldn't be captured in my data. And this is just by bed night and face-to-face. As you can see, the quota is far more likely to receive services than the other subgroups. Okay, so this is results of negative binomial regression, and in this, it shows that for those people who ever utilize services, all refugee subgroups were more likely to have several meetings or several contacts with mental health services, especially services, than the cultural refugees, and that was interesting to me. So, so it seems like many of cultural refugees, 35% of them, 38% of them had one contact, but not necessarily in follow-up contacts. That suggests the data suggests this. So I looked at different by different organizations providing these services, and like cultural refugees by far were more likely to be seen by NGOs than the other like convention, and also other populations, New Zealand populations, like overseas born and New Zealand born. Then I looked at how refugees refugees sterilization compares with New Zealand born population and overseas born population or immigrants. And as you can see, like cultural refugees, again, that the difference, it looks to me like the difference is of time to the first event is for that first bit of a few weeks of being in New Zealand, and that could very much be again, West New Zealand providing some of the face-to-face services in Mangere in the first 5 weeks of arrival for cultural refugees. But like New Zealand born is also picking up fast over time. And then for the case identification, I just put some results for that one just to show you how they compare over the years. So anxiety and mood wasn't picked up from, so primed was like between 2001 to 2004, prime was the main one, which I didn't use diagnosis code from prime because over time the quality of data wasn't similar. But like, so this also includes pharmacological data. As you can see, like this is the black line is refugees line. The blue line is NZ born, and the yellow line is overseas. And so, like over time, the prevalence of prevalence of having anxiety or mood. So I would love to look at PTSD specifically for refugees, but like because of the low numbers within each year, that would have been suppressed. The numbers would have been suppressed. So I had to merge depression and anxiety together and put it like as a mood and anxiety even. This is substance use. So this is a New Zealand born, this is refugees over time. So the refugee and overseas born population over time is increasing as more refugees are coming in the country. And this is the psychotic. So compared to the international literature from the prevalence of psychotic disorders in refugees is about, it's quite a different range, but like a literature review of, like a systematic review of quite a few countries. For those people who have been in camps, refugee camps, it's been 27%. So it's not high for refugees in New Zealand, really, compared to that. And sleep disorders, if you call it a mental health issue or not. But so, yeah, that's the prevalence of sleep disorders over time. So other mental health issues, so other small ones, because ADHD or dementia, or like many of these mental health disorders that are not specifically for adults aged between 16 to 65. So I just merged all of the other conditions together. And yeah, that the rates in refugees and the prevalence in refugees over time is higher than other subgroups. And this is potential mental health disorder, and this is just from the pharma data based on drugs that could be potentially related to mental health conditions. And then again, it seems like refugees have been using, and that reflects to some extent the primary health care from physicians at the first point of access for refugees for their mental health. So what I found in this, to this point, I need to do some modeling for those specific mental health conditions, and hopefully next year I'll present them if I'm still a research fellow. So refugees' mental health use differs between subgroups of refugees, and that's reflective of the settlement programs and the policies for refugee subgroups. In 2012, the settlement program was for Kota refugees to provide basic information to provide basic needs of refugees for the first year, and then they increased to 2 years. The first 2 years of their arrival, which means that including like mental health services, primary health, finding jobs for refugees, helping them to get into education, housing, providing for their housing, but that excluded other subgroups like convention refugees and family. And like the results of this study clearly shows that that policy impacted these groups, and that doesn't necessarily. And then I found that like more of the conventional asylum seekers were hospitalized when they were finally approached mental health services. We don't know how many of them were left that they needed help earlier, and how many of these hospitalization events could have been prevented had they been seen by mental health providers and supported by them earlier. So thankfully, like a few weeks ago, the new resettlement strategy, the refreshment, included other groups of refugees in the settlement program, which is a good news. It shows that the Immigration News has heard the message from the sector that we really need to be more inclusive. But so obviously this data doesn't show how many of our refugees. So the good news is that our NGOs could provide some support for Kota refugees, but we don't know how many people they left who were in need of mental health services early on. So I'm gonna skip this one. The challenges of IDI work. But the next step for me is, so I've already looked into long-term income of refugees, and also education of these refugees. So the next step is to put all of this data about mental health and hopefully physical health, education in the long term, and income, to see if I can look at overall well-being of refugees within the IDI. It won't be a perfect approach, but that could shed some light on refugees' life journey in New Zealand. And hopefully in the future we can do surveys on refugees, and they can hear their journey firsthand from themselves, bring voices of refugees from qualitative and further quantitative data into what we found in IDI. And I would like to acknowledge everyone who helped me along the way. Professor Germano, Center for Asia-Pacific Refugee Studies, Auckland Medical Research Foundation, campus team, everyone in the campus were so helpful to me. Everyone provided so much help along the way. So thanks to all of you. And my colleague Frederica from Otago University and in Wellington, she helped me a lot, and yeah, she continues to help me. Annie was sitting here, who helped me along the way, and she's done an amazing job with the mobility of refugees. Hopefully our paper is published soon, so we can share more about that. And all of the advisor groups. So we had refugee advisor groups, including mental health service providers from US New Zealand, clinicians and directors who were providing me with some insights about what data tells me, why data tells me what it tells me. And yeah, they were really helpful. For example, for those people who were 16 to 24, I was asking them why they didn't reach mental health services as much as other older groups. And they were like, because they are not in an age to be in the high school or to be really up in the labor market, and these are left out population usually, and it was quite normal for them, or like convention refugees less likely, or family less likely to be seen. And so thanks to all of them, they provided me so much help and insights, and continue to do so. Oh, last slide. So this is a poem from Rumi. And this slide is just about the woman life freedom movement last year in Iran, which ended up killing many people by the states because of compulsory hijab or a little freedom for women. Many people got displaced and left the country afterwards, which connects me to this research more. Thank you. Questions?
The graphs you were showing of like your kind of time series analysis, is that at each time point, is that just like the total refugee population in New Zealand at that current point in time? Or have you done any like cohort kind of analysis?
It's cohort kind of analysis. These ones are cohorts, and this one is timed to the first event. So it doesn't include multiple events. But this is a cohort.
So it's one cohort being tracked over.
No. So the people are being added, so in different years. So this is a year of analysis, really.
Okay.
Have you done any looking at like one cohort over time?
It's a little bit difficult because of the numbers. At least for specific mental health events, I can't do that. I can do for refugees altogether. From certain cohorts maybe, but like it's mainly for quota refugees. Then the other refugee subgroups will be left out because the numbers were too small.
So I guess following on from that, it seems as if a lot of the refugee cohorts are quite noisy compared to the others, and that's because of the small sample size. Okay.
Yes.
And is that also influenced by the entry of different groups? Like a large cohort of people come in from like Africa or sub-Saharan Africa or Middle East.
So the time series analysis has been done on these ones. Time to the first event ones. They are after 2001. They are limited to 2001 because like mental health service utilization data was available from there. The large number of people coming were mainly from 2000 and 1999, a lot before 2001. So after this, proportionally, they weren't like any large groups of people arriving. Mass arrival. We don't have mass arrivals. I mean, at least after 2000 for refugees.
Hi, I have a question regarding your slide number 16. If you can go to that, please.
This one.
Yeah, thank you. I can see there's some fluctuations between 2013 to 2019 for the refugees. Do you have any insights on why there's some fluctuations? That's one question. And then I also want to know what is the implication of your research, and have you shared these findings with the NGOs working in that space?
Thank you so much for your question. So I haven't done modeling on this yet. So I need to control for age and gender and all of those factors to understand what are the differences. And I'm also doing a lot of subgroup refugees. So there might be a specific subgroup that like increase in that year. So I need to do those ones separately to understand. So I don't have the answer to the question yet. Yes, results of up to this slide. These results are also presented to quite a few of the like refugee NGOs who are providing mental health services. I've also presented this to the refugee resettlement forum, which was held 2 months ago in July in Wellington. So in the pre-forum presentation, I provided a lot of information about mental health and economic outcomes of refugees. So RAS New Zealand continues to provide a lot of information for me. So I'm very thankful to them for keeping in touch. And hopefully we are writing applications to do more research on refugee kids because these results are just on adults. So I'm trying to find the kids and first and second, 1.5 and second generation refugees to see how it differs for them.
So my question is on the source of the diagnosis that you got, the mental health diagnosis. So in the IDI, you can get data from publicly funded hospitals only, right?
Yeah.
So these refugees, are they covered by the health insurance system here? so that you know, like, most of them are accessing publicly funded hospitals, or is there another way you can get data from private GPs, or even these NGOs that you spoke of that provide care, do they report data into the IDI?
Thanks, that's a very important question. So your data on diagnosis, as I said, is mainly from hospitalization. The rest of them is, so if, like from Prime, I didn't look into diagnosis data because like Ministry of Health and my health researchers, they indicated that over time, the diagnosis report is very different and very incomplete. And even different DHBs provided at different levels of diagnosis in there. So I didn't use that, but instead, like for psychosis, we use team type. So if they use that team type, then that's psychosis. And then if not, then that goes into the other mental health. So for some reason, so for some other mental health conditions, they use that. For pharmacological, based on the type of the drugs they were using, they are assigned as having a specific mental health condition. But from GPs, not, I mean, there's no, that's the only way we can look at the GP or the first, like the primary healthcare, mental health. So there's no diagnosis data from there. Yeah, the only way to get to that is from pharmaceutical data. Thank you. Answer your question. Please ask if I haven't.
No, then I think I asked you, like, are these refugees covered by the health insurance?
The first 2 years, for some time, I mean, yeah, community refugees for the first 2 years, yes, but I'm not quite sure for how long other refugee subgroups are. So yeah, I'm not best to provide that answer to the question. Yeah. But I can ask.